I am Werner Schultink, the Executive Director of the Iodine Global Network, or IGN in short. IGN has been working for more than 35 years towards the sustainable elimination of iodine deficiency across the globe. Our aim continues to be to protect this great public health achievement and to reduce iodine deficiency in countries and populations where it is still a problem. Today's seminar aims to review and discuss these two public health strategies and objectives. From IGN's perspective, these are perfectly compatible. Technically, it is easy to adapt the level of fortification so that when people consume less salt, they still get enough iodine and still being protected from both the non-communicable diseases as well as iodine deficiency.
It's very important progress through the measurement of goiters. On the left side you see the status in 1993, on the right side in 2019. And the bubbles represent the size of the magnitude of goiter, which is one of the clinical signs of iodine deficiency. And you see that the rates in the 1990s was very high. Now this slide, let's look at the progress in South Asia. It's been huge progress in the last 20 years or so. So the South Asian countries have scaled up programs that largely provide adequate iodine to the population. However, still some regions and people are iodine deficient, and also technical assistance and information exchange can really benefit from working together.
My name is Michael Zimmerman, and I'm a professor of human nutrition at the Swiss Federal Institute of Technology in Zurich, Switzerland. I'm also the chair of the Iodine Global Network. Iodine deficiency remains a major global health problem. Iodine deficiency disorders for many years have been one of the most common human diseases and one of the most common causes of preventable mental retardation around the world. Using salt as a fortification vehicle in poor areas of rural subsistence farming in Africa and Asia is not only an effective choice, but it's often the only choice. Stated that at the country level, close collaboration between salt iodization and salt reduction programs is urgently required so that their aims are congruent. Policies for salt iodization and reduction of salt intake are compatible. However, impact on iodine intakes of salt reduction will be highly context and country specific. And because of this diversity, a generalized iodization standard probably will be of only limited value as salt intakes fall. And I think as we reduce salt intakes in the population, it's going to become more and more important to carefully monitor iodine status using urinary iodine concentrations and tailor the iodine content in iodized salt in order to maintain adequate intakes in the population.
There's clear evidence that there is a direct relationship between sodium consumption and blood pressure. Eating too much salt or sodium causes raised blood pressure and thereby increases one's risk of cardiovascular disease as well as chronic kidney disease. So in 2019, there were 96 countries with national salt reduction initiatives around the world. That's almost a 30% increase from 75 national strategies in 2014. The third most common intervention is any sort of consumer education initiative, whether that's awareness raising campaigns, mass media campaigns, or behavior change communication strategies. So the last two salt reduction initiatives include front of pack labeling and tax on salty foods. So the first parallel that can be leveraged is the methods in monitoring and surveillance, salt and iodine in the same surveys. They are not only huge savings in cost and time, but it also reduces the burden on the population being surveyed.
I'm going to talk to you about the effects of reduced sodium, added potassium salt substitute on stroke, and these are the results of a a large trial that we reported in the New England Journal a couple of months ago. Combine these two effects with clear benefits for blood pressure lowering in randomized trials. So you basically, instead of having 100% sodium chloride, you replace some of the sodium chloride in salt with potassium chloride. Was that at the end of the 5-year follow-up, 92% of the participants who were still alive were still using the salt substitute, which is a really high proportion of adherence. So what did we see? Well, this is the Kaplan-Meier plot for the main results. Overall, we recorded about 3,000 strokes during the study in about 2,500 people. So major adverse cardiovascular events, well, there were almost 5,000 of these vascular deaths, strokes or heart attacks recorded during the study in about 4,500 people. And you can see here that there was a 13% reduction in the risk of having a major adverse cardiovascular event. And once again, a very clear result with a p-value of less than 0.001. So for mortality, there were 4,000 people who died during the study. There was a 12% reduction in the risk of premature death. And once again, really no uncertainty about that with a p-value of 0.001. So if you switch to a salt substitute instead of regular salt, you are reducing the risk of premature mortality. So the study had some significant strengths. It was large, it was long-term, and it studied definitive outcomes. It had a very pragmatic approach to putting people in, which is potentially easily generalizable at a population level. In terms of the potential events that could be averted if salt substitution of the form we achieved in this study was implemented nationwide, you would end up averting almost 1 million major cardiovascular events each year. However, we don't think the result is only applicable to Chinese people. The physiology that manages sodium, potassium, blood pressure, cardiovascular risk is highly constant across diverse populations, and we think the result is probably relevant to everyone that eats salt. It's most relevant to the 5 billion plus people who consume most of their dietary sodium as the discretionary salt that Kathy mentioned, that salt added at the home, at the time of cooking. What do we want to see following these results? Well, we'd like to see salt manufacturers and retailers worldwide switching to producing and marketing salt substitute at scale and ultimately replacing the salt supply globally with a salt substitute supply.
On WHO's perspective and future role in salt iodization and salt reduction. Now, prevention and control of non-communicable diseases, including cardiovascular disease, is one of the flagship priorities of WHO Southeast Asia region. And preventing and managing cardiovascular disease and hypertension is an essential component of that priority. The key point is that both salt iodization and salt reduction programs are equally important. And we saw that there's much more to ensure universal salt iodization coverage, and there's a lot more work to be done in that area. In most of the STEP surveys, we also advocate a component of 24-hour urine collection, though it is not always done depending on the country context. And some countries are already started this work and carrying on this work, but much more effort is needed. Even in this part of the world, the processed food consumption is increasing gradually, and therefore the regulatory aspects have to be made and implemented, while we also address the issue of discretionary and added salt. Now, low sodium salt, I'm sure has a role in sodium reduction, but have to be one of a menu of structural and educational strategies to reduce salting. Now, WHO will be providing new guidelines on low sodium salt substitutes soon, and also continue to support the countries on both salt iodization and salt reduction efforts.
As a South Asia Regional Hygiene Coordinator, it is nice to start the year in addressing these two of the important public health interventions in Asia. I think today we have listened to very eminent speakers in the globe, starting from the Dr. Werner Schulkin, then the Dr. Arnold Timmer, Professor Michael Zimmerman, Dr. Kathy Trew, and Professor Bruce Neal and the Dr. Angela De Silva. So this is a very high level of panel. We are very fortunate to have all of you today. This seminar highlighted the need of regular monitoring of salt iodine content as well as the urine iodine concentration and reduction of salt as well. So it further provided the cost-effective options for salt reduction while maintaining our food cultures in a meaningful way also. And thank you for all national IGN coordinators and all the participants. And I must appreciate the large number of participants from Pakistan, and thanks to the effort of our national IGN coordinator, Faiz. Iodine Global Network hope you have gained an adequate knowledge to look at positively these two programs in the future, especially within the South Asia region. So thank you all of you.